This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
In our last lecture, we reviewed some basic information about Parkinson's disease, including signs and symptoms of the disorder, underlying brain pathology, and how this disorder is distinguished from Parkinsonism and essential tremor. In today's lecture, we're going to investigate how gender and site of disease onset affect the presentation of Parkinson's disease, as well as potential causes of the disorder and some of the current treatments. Let's start with gender. Research shows that men are likelier to get Parkinson's disease than women by a ratio of about 2-to-1. Some speculate that estrogen serves as a protectant factor for women. Women are also typically older than men by about 2.1 years when they are first diagnosed, and they are more likely to present with an initial motor symptom of tremor compared to other motor symptoms like slowness of movement or rigidity. Women also report lower levels of quality of life and more depression than men. So these are some of the limited things we currently know about gender differences in Parkinson's disease, but clearly more research is necessary on this subject. Turning now to motor symptom onset, recall that Parkinson's disease has a unilateral motor onset, which means that initial motor symptoms typically present themselves on only one side of the body, so the left side or the right side. Over a period of time, the disease spreads to the other side, so the symptoms then become bilateral, presenting on both sides of the body. Remember also that the affected area of the brain controls the opposite side of the body. So if the right side of the brain is affected, symptoms will present on a person's left side. What's interesting is that the side that is initially affected generally remains more impaired than the one affected later. So when you compare, for instance, the cognitive and visual deficits of Parkinson's patients with left-sided symptom onset to those in patients with right-sided symptom onset, you can see distinct differences between them. Remember that the right hemisphere in the brain is associated with visuospatial abilities, including visual memory and global processing, so seeing how individual objects fit together in the bigger picture. By contrast, the left hemisphere is associated with verbal information, including speech and verbal memory, and detailed or local processing, so focusing on individual items and not the bigger picture. Based on this information, we can actually predict how a Parkinson's patient with a left-sided symptom onset might differ from a patient with a right-sided onset. If symptoms first appear on the left side of the body, which is controlled by the right side of the brain, patients are likely to exhibit deficits in visuospatial processing and global processing. And if the symptoms first appear on the right side of their body, controlled by the left side of the brain, they are more likely to exhibit deficits in verbal memory and local processing. Some of the visuospatial problems in Parkinson's patients with left-sided symptom onset are absolutely fascinating. In a 2001 study, Dr. Allison Lee and colleagues asked patients with left-sided symptom onset, those with right-sided symptom onset, and age-matched control participants to indicate whether or not they thought they'd fit through various life-size doorways projected onto a large screen. Patients with left-sided symptom onset had a lot of difficulty performing this task. In fact, they experienced something referred to as spatial compression. When shown doorways that they could clearly fit through easily, they responded that they didn't think they could actually fit through them. It's almost as if they viewed the doorways as if they were smaller than they actually were, as though they were somehow compressed. By contrast, neither patients with right-sided symptom onset nor age-matched control participants experienced any type of spatial compression. In a separate 2005 study by Dr. Rosa Davidsdottir and colleagues, Parkinson's disease patients with left-sided symptom onset reported bumping into the left side of doorways much more frequently than the right side of doorways, something patients with right-sided symptom onset did not report. Could patients with left-sided symptom onset be experiencing some type of mild neglect? So difficulty with attending to the left side of space? If you remember, we talked about neglect earlier in this course when I talked about my mom. The type I'm referring to here is a much milder form of that. In fact, in a separate 2001 study, Dr. Allison Lee and colleagues found that on a classic line bisection task, Parkinson's patients with a left-sided symptom onset bisect the line to the right of the true midline, just like spatial neglect patients do. An additional experiment by Dr. Davidsdottir and her team in 2008 also found that patients with left-sided symptom onset tended to veer to the right of center when they walked, lending even further support for the existence of a mild neglect syndrome in these patients. In addition to gender and location of symptom onset, a couple more variables are worth considering. One is age. Typically, those who get Parkinson's disease much later in life have a poorer prognosis and show deterioration more quickly than those with an earlier age of onset. Another variable is the type of motor symptom the patient first exhibits. Patients whose first motor symptom is a tremor generally have a better prognosis than those whose first motor symptom is rigidity or slowness of movement. As to prognosis, about half of all Parkinson's disease patients go on to develop subcortical dementia, which you'll recall refers to a group of symptoms associated with a decline in memory or other thinking skills that interfere with a person's daily functioning. We'll be talking about Parkinson's disease dementia in a later lecture. People who develop Parkinson's later in life and who have had symptoms for a long time are most at risk. Usually those who end up developing dementia do so about 10 to 15 years after they are initially diagnosed with the disease. When it comes to potential causes of Parkinson's, the jury's still out, though several studies support the idea that both genes and the environment are contributing factors. In fact, it's the combination of these factors that is believed to structurally alter a person's DNA, which results in the onset of Parkinson's disease. Let's take a look at genetics first. It's not quite clear how much genetics plays a role in the onset of Parkinson's disease, but many scientists believe that genes play a much more significant role in those who first show symptoms before the age of 50. Note that just because someone possesses the genetic risk factors associated with Parkinson's disease in no way implies that they will actually get the disorder, since environmental factors play a significant role in activating these genes. The online database, www.pdgene.org, provides an exhaustive account of all published studies, over 800, examining genes associated with the onset of Parkinson's disease. A wide variety of genes have been examined, but results vary considerably across studies. Some of the genes that show consistent associations with Parkinson's disease include those known as SNCA, GBA, and LRRK2. SNCA stands for synuclein alpha. This gene has a variety of functions, one of which is to help regulate the release of dopamine in the brain. So far, at least 30 mutations of this gene have been found to cause Parkinson's disease and are mainly associated with the early onset form. Other variations of this gene increase the risk of late onset Parkinson's disease, but they are not believed to be the direct cause of the disorder. When mutations do occur, excess SNCA proteins cluster together to form Lewy bodies, which impairs the functioning of neurons in specific regions of the brain. The next gene, GBA, stands for glucocerebrosidase. This gene provides instructions for making an enzyme important for cell functioning. GBA mutations occur twice as often in early onset Parkinson's disease as they do in late onset Parkinson's. Patients with this mutation also tend to have more cognitive deficits. Mutations in GBA reduce the amount of an enzyme that prevents the buildup of toxic substances within cells, thereby resulting in damage to specific areas of the brain implicated in Parkinson's disease. Finally, the gene LRRK2 stands for leucine-rich repeat kinase 2. This gene plays an important role in brain cell structure and function. More than 100 mutations in this gene have been reported among patients with late-onset Parkinson's, though only a few have been proven to cause it. Mutations impact brain cell function and structure by affecting a protein called dardarin. It's currently unclear exactly how the LRRK2 gene mutations lead to movement and balance problems that are evident in Parkinson's disease. In sum, scientists do believe that several genes are associated with Parkinson's disease, but it remains unclear whether these genes relate to different types of onset patterns, different forms of the disease, different symptoms, and so on. Clearly, a lot of studies still need to be completed in order for us to make more definitive statements about the genetic basis of Parkinson's disease. Let's switch gears now to talk about the environment. As it turns out, numerous environmental toxins have been linked to Parkinson's disease, including exposure to heavy metals, pesticides, and herbicides. Many studies support the notion that chronic lifetime exposure to heavy metals, such as copper, manganese, or lead, increases a person's risk of developing Parkinson's disease. Research on mercury is conflicted. Some studies find a link to Parkinson's disease, while other studies do not. It is not quite clear how long a person would need to be exposed to heavy metals, how many heavy metals would be required, or how much the exposure risk varies from person to person. These are all questions that will need to be fleshed out with future research studies, but suffice it to say that chronic exposure to heavy metals does increase the risk of developing Parkinson's disease. What about pesticides and herbicides? Just like heavy metals, a wide variety of pesticides and herbicides have been examined in research studies to determine which ones are associated with an increased risk of Parkinson's disease. Some show a link across multiple studies, whereas others show conflicting results. 2 pesticides, Meneb and rotenone, and 2 herbicides, 2,4-D and paraquat, show significant links to the onset of Parkinson's disease, although results across studies are inconsistent. The herbicide 2,4-D was an ingredient in Agent Orange, which the U.S. military used to clear trees and vegetation during the Vietnam War. While we know these pesticides and herbicides are associated with Parkinson's, we do not know the level of exposure necessary or in what concentration they need to be for them to trigger the onset of Parkinson's disease. In fact, we don't even know if consuming food that has been treated with these chemicals increases our risk. This and many other questions remain to be answered. A final environmental risk factor that I want to mention is a history of using illicit stimulants. 3 psychostimulants have been implicated in the development of Parkinson's disease: amphetamine, methamphetamine, and cocaine. All have been shown to play a possible role in the neurodegeneration of the brain. It's currently unclear how factors like dosage and length of time taking any of these drugs contributes to disease risk. So is there anything we can do to decrease our risk of getting Parkinson's disease? Research shows that moderate to vigorous exercise is associated with a lower risk of acquiring the disorder. Gut health especially matters. Studies show that intestinal inflammation, including having constipation, is associated with an increased risk of Parkinson's disease. Significant emotional stress may also increase one's risks. There is, unfortunately, no cure for Parkinson's disease. At this point, all we can do is treat some of the symptoms in order to increase the quality of life for those affected by the disorder. So let's go over some potential treatments. We'll start by talking about medications. A variety of medications are used to help alleviate or dampen some of the symptoms associated with Parkinson's disease. The types of medications and their dosages vary greatly from person to person, and there is frequently a lot of trial and error involved to get the medications just right. Currently, the most popular types of medications for treating Parkinson's disease are carbidopa-levodopa, dopamine agonists, MAO-B inhibitors, COMT inhibitors, anticholinergics, and amantadine. Although these medications work in different ways to control some of the symptoms of the disease, their effectiveness unfortunately tends to diminish over time. Now, let's take a brief look at each of these medications. First, we have carbidopa-levodopa. Levodopa is a naturally occurring chemical that can be converted into dopamine once it enters the brain. As we've already discussed in our last lecture, dopamine is the primary neurotransmitter implicated in Parkinson's disease. Carbidopa prevents the levodopa from converting to dopamine before it passes into the brain. This is important because dopamine itself cannot pass through the blood-brain barrier to get to the brain. Side effects of this medication combination can include nausea, lightheadedness, and sudden involuntary movements. The next category of medications is that of dopamine agonists, which mimic the effects of dopamine in the brain. These are generally not as effective as carbidopa-levodopa, but the effects seem to last longer. Side effects of these drugs include nausea, lightheadedness, drowsiness, hallucinations, and compulsive behaviors, such as gambling, overeating, and hypersexuality. I always found the gambling side effect interesting. So in many cases, after starting the drug, caregivers notice that their loved one develops an online gambling addiction. MAO-B inhibitors help to prevent dopamine from breaking down, which makes more available for the brain to use. The side effects of these inhibitors include insomnia and nausea. Another category of drugs, COMT inhibitors, prolongs the effects of levodopa by blocking brain enzymes that deplete dopamine. Some of the side effects of these drugs include involuntary movements and diarrhea. Anticholinergics are used to help combat the tremors associated with Parkinson's disease. Side effects can include confusion, hallucinations, memory loss, constipation, and urinary problems. And finally, amantadine causes greater amounts of dopamine to be released in the brain, thereby helping to relieve some of the symptoms associated with Parkinson's disease. Side effects include dizziness, dry mouth, swelling in the legs and feet, nausea, constipation, and insomnia. As you can probably guess, most people with Parkinson's disease are on some type of medication regimen. They take medications for a variety of symptoms, though, not just those mentioned above that primarily relate to motor functioning. Other common treatments for Parkinson's disease include deep brain stimulation and focused ultrasound surgery. Let's start by talking about deep brain stimulation, or DBS, which involves surgical intervention. Here, electrodes are implanted into a specific part of the brain based on the patient's symptomatology. Brain targets typically include the thalamus, the subthalamic nucleus, which is located just below the thalamus, and the globus pallidus interna, which is a segment of the globus pallidus in the basal ganglia system. These implanted electrodes are connected to a generator, like a pacemaker-type device, implanted in the patient's chest. The generator sends electrical impulses to the brain to help reduce the patient's Parkinson's symptoms. This procedure tends to work well for symptoms of tremor, rigidity, and slowness of movement. It does not work so well for symptoms of imbalance, freezing of gait, or non-motor symptoms. Patients who are good candidates for this procedure tend to show a robust response to levodopa, show no significant cognitive or psychiatric symptoms, and have no significant issues with balance. Research shows that this procedure helps patients with medication-resistant tremors, those who have significant motor fluctuations, for which the effectiveness of medication varies during the day, or those who experience extra unwanted movements as side effects of the medications. Focused ultrasound surgery is similar to DBS in that the same brain areas are targeted. However, in DBS, small electrical impulses are delivered to interrupt abnormal signaling, whereas in focused ultrasound surgery, cells are actually destroyed. In focused ultrasound surgery, doctors use MRI brain scans to direct ultrasound beams to target locations. In this case, either the thalamus, the subthalamic nucleus, or the globus pallidus interna. Cells in the targeted area are destroyed, decreasing symptoms immediately. The patient is awake during the procedure, so no general anesthesia or surgical incisions are involved. The procedure is also only done on one side of the brain, and the results are irreversible and permanent. This is different from DBS, where adjustment and programming changes can be made. Medications, DBS, and focused ultrasound surgery are all common and effective treatments for Parkinson's disease. Different patients will respond better to different treatments based on their symptoms and needs. In addition to taking medications or possibly undergoing DPS or focused ultrasound surgery, patients may also want to explore physical, occupational, or speech therapy options. Physical therapy could help improve gait or even supply patients with an exercise program to help with mobility. Occupational therapy might help to maximize fine motor skills. And speech therapy can address various speech and language issues. As we mentioned earlier, regular exercise can decrease the risk of getting Parkinson's disease. And it can also improve symptoms in those who have it. Recommendations for individuals with Parkinson's disease include things like cueing strategies, so external cues of some kind to improve motor movements. Cognitive strategies that can be combined with movement in some way. Exercises to improve balance. Exercises to improve joint mobility and muscle power. And some kind of aerobic training. One activity that checks off all of these boxes is ballroom dancing, like learning how to tango. First, it uses external cues, so music, to facilitate movement. Second, dancing consists of learning very specific movement strategies. Third, learning how to dance with a partner requires knowing how to control your balance. Fourth, dancing enhances strength and flexibility. And fifth, it's an excellent form of aerobic exercise. Research shows that dancing does result in a variety of motor and cognitive benefits for individuals with Parkinson's disease. And not only that, people are actually interested in doing it. It's a much more enjoyable and engaging activity for many than walking or running on a treadmill. So get your dancing shoes on, as this type of exercise benefits everyone, not just those with Parkinson's. Okay, this concludes our two-part discussion of Parkinson's disease. Next up is another two-parter, this time on strokes. See you then.